Good morning. Thank you so much for having me here. How many of my good pre-hospital EMS providers do I have? Almost all in the back row as usual. Nursing staff in hospital. Okay, that's the majority of physicians in hospital. Okay, great. My hope is to take what is a often talked about subject and put a little different twist on it today. And the first thing I want to say about that is that the power to question is the basis of all human progress. And if there's anything you remember from the lecture today, it's the following. There is not a single published study that demonstrates improved outcome from pediatric intubation in the pre-hospital environment. Not a single one. So this notion that airway management equals intubation and that that's where we need to be focused is not an evidence-based concept. And my hope is that by the end of this, that we look at airway management more broadly from a physiologic perspective as opposed to from a procedural perspective. This is what we're going to do. I'm going to have to, unfortunately, talk about physiology briefly. And I realize that that's a dangerous thing to do at a conference like this, but to get us into the right frame of mind, we're going to briefly talk about that. And then we're going to talk about some practical considerations for managing that airway in a trauma case. We've got 3 illustrative cases from our system. And to make sure that we can identify the patients, I won't give you the time frame because the rest is all in there, but there are 3 trauma airway management cases that I think are illustrative of the issues, and then we'll have some take-home messages at the end. So if you're wondering which type of lecture this is, it is not the one to the left. I took step 1 of the boards, I figured out how many ATPs are made each time you go around the Krebs cycle, and I promptly forgot it and have never thought about it again. So we are now on the other side talking about what we really do in the real world. In other words, when we encounter that injured pediatric patient, what is the best approach both in the pre-hospital and in-hospital environment as it relates to their airway? So the holy grail of paramedicine used to be this, right? And we called it the ABCs, and if you ever had to take your national registry exam on the paramedic side, it was always what? IVO2 monitor, and then you follow by the ABCs. That was just this fall off a log kind of thing that we all did. In point of fact, however, airway management came to equal intubation. So what we really practiced was the IBCs. Intubate, then breathing, and then circulation. And my hope is as we get to the end of this, we understand that's not the approach that we want to take. So the first basic physiologic review is this. Oxygenation and ventilation are not the same thing. And unfortunately, we put these 2 things together, and here's my favorite statement when we're preparing to do an RSI. Somebody says, let's pre-oxygenate the patient. And what do you commence to do? Hyperventilate the patient. That has nothing to do with oxygenation. If you want to pre-oxygenate, what you should do is put them on high flow O2 5 to 10 minutes before the procedure and allow their oxygen levels to rise. But because of that statement that is made at the head of the bed across the country, we then become confused, and when the patient is ill and they are hypoxic, we then believe that squeezing the bag faster will make them better. And that is a fundamentally flawed concept, and we'll talk about that momentarily. So the notion is if we want to change a patient's oxygenation, we do that by fixing whatever the problem is at alveolar-capillary interface, be that edema, be that injury, be that blood, be it whatever, and we change the inspired fraction of oxygen. If we want to change their ventilation, we talk about tidal volume and respiratory rate. Now, obviously, this is not a hard and fast line. You can have a respiratory rate of 0 and still oxygenate. But there's a point at which you get diminishing returns, and we'll talk about that. The reason that's important as it relates to a pediatric airway conversation is my hypothesis to you will be that I hope to demonstrate to you in the next little bit is that placement of the endotracheal tube, even when successful, which is an entirely separate conversation, allows one to hyperventilate in a manner that you cannot do with a bag valve mask alone. And so that instrument allows us to create potential problems, and we'll talk about that as we head into case review. So we've always talked about the ways that we measure oxygenation. The second take-home point, number 1, I hope, is that we're not going to intubate everybody. The second is that we're going to spend the money on continuous end-tidal CO2, not only in the pre-hospital environment, but in the in-hospital environment. And I'm not going to say anything about the facilities in this region. I'll just be happy to make fun of our own. We have a level 1 trauma center. We see 110,000 patients a year in the ED, 800 and some odd trauma activations, 200 penetrating trauma cases, et cetera, et cetera, et cetera. How many continuous end-tidal CO2 monitors do I have in my emergency department at my level 1 trauma center? 1. Singular. 1. And what is that used for? Conscious sedation, right? Because you have to have continuous end-tidal CO2 to do conscious sedation. It's a little handheld device, not even hooked into a monitor, that sits at the head of the bed. I have 75 ambulances will respond to 90,000 requests for service this year. I have 80 continuous end-tidal CO2 monitors in the pre-hospital environment because every single patient deserves that monitoring. It is fascinating to me that from the pre-hospital environment, we can monitor that airway second by second, and in the in-hospital environment, we can take a color change, remove it, and then have no idea what's happening to that airway going forward unless we're standing at the bedside. So the second thing is continuous end-tidal CO2 should be important. This is just to illustrate the physiologic change that I'm concerned about when we place the tube, particularly in the traumatically injured pediatric patient. In the days of polio, where we had the iron lung, there was actually a nice physiology that went with this. They're cumbersome, but they create negative interthoracic pressure. And negative interthoracic pressure gives you good blood pressure. For those of you that work in the ICU, I think we would all agree, the patient who is on the ventilator, the first thing that happens when their blood pressure falls is you go and turn down the PEEP, because you know you have filled that interthoracic cage with too much positive pressure and there's no venous return. Negative pressure in the iron lung was wonderful. Positive pressure within the tracheal tube allows us to decrease venous return and perhaps create worse outcomes for our trauma patients. And I'm hoping to convince you that in a moment. This is just the cross-section to remind everybody that the lungs and heart are in the thoracic cage. And so if you inflate the lungs too far, then you compress the vena cava. This seems obvious. It is easily forgotten. This is for those of you that went to NC State. If you couldn't understand this one, then you understand this one, right? It's a box. And if you put too much pressure in there, then you cannot get venous return. And in the low flow state in the traumatically injured pediatric patient, it is very easy for us to inadvertently hyperventilate, stack breaths, decrease the return through the vena cava, and cause worsening patient outcomes. So the placement of the tube gives us the tool that allows us to do that. So, two brief studies. The first is the San Diego study, and this study includes adults only. We'll get to a pediatric study in just a moment, but I think it's illustrative. These authors are truly attempting to set the world record for the total number of studies published from a single data set. But that's okay, because it's pretty interesting. And what they did actually is very helpful to us, I think, as we go forward. So they thought, this makes sense. If we manage the airway in a trauma patient in an aggressive way, then we should prevent hypoxia. And we all know that a single episode of hypoxia doubles your odds of bad outcome. So we want to make sure that we do that. And they want to get all their paramedics through and teach them how this could be done. Now, the thing to remember here is that in San Diego, there's a paramedic on every engine and every ambulance that responds. So on average, these medics would see one airway every 2 years. So this is a very diffuse ALS type population. So that's one thing to keep in mind as we talk about this study. So they went under an 8-hour training session. Now this is the first question that people would have, is can you truly learn all RSI pharmacology, all the GCS scoring, and the study protocol in 8 hours? Some would say yes, some would say no, but that's what they did. And so they looked at that group over an 8-hour time frame. The study went on for 2 years. So there was a singular 8-hour education, and then there was a fairly significant time frame under which the study was conducted after that. These are the inclusion criteria. As I said, this is an adult study. Over 18 years of age, they had to meet the trauma criteria. They had to have an apparent head injury with a GCS 3 to 8 and an estimated transport time of at least 10 minutes to the trauma center. If you met those criteria, then intubation was attempted without RSI in all patients. So all patients had a GCS of 3 to 8. They attempted to intubate without any drug facilitation at all. And if they were successful, then off they went. If it was unsuccessful, and here's the next part where people have some interesting comments about this study, if your systolic blood pressure was greater than 120, you received sedation. If it was less than 120, you were paralyzed without sedation. Interesting approach. For the majority of this study, as we already reflected on, only the colorimetric CO2 was available. But there's a subset for which the continuous was available that we'll talk about. So that was the protocol. The exclusion criteria were if you could not ever secure an airway, they put them in a separate category. If it turned out you were only intoxicated and did not actually have a head injury, then you were excluded. And then if there was death in the field or within 30 minutes of arrival in the trauma bay. So we could have an entire journal club about the design of this study for obvious reasons. But the point is this. When you looked at the controls as compared with the group that received RSI, and you looked at mortality all comers, in a statistically significant manner, those that received RSI were more likely to die. And conversely, you were less likely, in a statistically significant manner, to leave the hospital neurologically intact. So RSI increased mortality and decreased the overall odds of neurologically intact survival in this group of trauma patients in this study. And again, my sister went to NC State, but I can still make fun of them. If you didn't get that, then here it is in the bar graph. Mortality high, neurologic outcome low in the RSI group. Now, the interesting thing is they went back and did a subgroup analysis. And what they were able to find, and there's a data dredging component to that for the scientific purist in the room that you have to put the caveat, they went back and data dredged. However, when they went back and dredged these data, what they found is that the end-tidal CO2 value predicted all of this mortality. In other words, placement of the tube allowed you to hyperventilate, which then allowed the bad outcomes to occur. If you corrected and allowed the patients who had a normal end-tidal CO2, who were not hyperventilated, the mortality difference almost washed away completely. There was a slight hypoxia question, this is a separate discussion, but the overwhelming majority of this can be attributed to inadvertent hyperventilation because the tube had been placed in the pre-hospital environment. There is one pediatric study, and this will never be repeated, and it's interesting. And for those of you that have been in the field, you know this study well, so I'm not going to dwell on it other than just to point out a couple of things about the study that sometimes are overlooked. This is the Marion Gachet-Hill study out of LA. We're all familiar with that. The interesting part is the second bullet here gets overlooked. And the second bullet is there was no difference in outcome, either to survival or neurological impairment, whether the pediatric patient received bag valve mask or pre-hospital intubation. We're all going to focus on the second part, which I'll show you in a second, which is the headline that comes from the trial. But the first part of it is there was no difference whether you bagged the patient or you tubed the patient in the pre-hospital environment if they were pediatrics, whether they survived or what their neurologic outcome was. But the headline became this, which is the take-home, the headline, the sensational part of the paper, which is 2% of the patients had an esophageal intubation apparently from the get-go that was not recognized. 6% had an unrecognized dislodgement. So they felt, based on monitor data, the tube was initially appropriately placed, but it became dislodged during transfer, and that was unrecognized. So you put that together, that's an 8% unrecognized esophageal intubation rate from EMS providers and pediatric patients prior to ED arrival. And most folks, I think, would argue that an 8% unrecognized esophageal intubation rate is unacceptable. Come down, there was another group, another 8%, where it was dislodged en route, but it was recognized and they went to some other airway. So that was a recognized dislodgement. So you put it all together, and there's a 16% dislodgement rate in some way or another, and there was only a 15% success rate overall for the intubation attempts. So based on this study, which is now 13 years old, this is done in LA, LA Fire does not allow pediatric intubation as part of their scope of practice. So paramedics in LA do not intubate patients under 12 years of age. Other systems have adopted that. I'm going to make an argument, I hope, as we go along, that perhaps that's a little dramatic and we can talk about a middle-of-the-road approach. But this is the paper, if you talk about pediatric airway management in the pre-hospital environment, that is clearly the most quoted paper in the literature and has been ever since it was published in JAMA. So this then leads us to the next question. So let's say we assumed it's properly placed, and we can now hyperventilate. The next question is it properly placed? And this is where I hope we can make the stringent argument for end-tidal CO2. So there was one study that demonstrated a 5% miss rate for all comers, all ages. The second study, probably the most famous out of Orlando, demonstrated a 25% unrecognized esophageal intubation rate for patients crossing the ED threshold from the EMS providers in that region. 1 out of 4 were not correctly placed at the time of transfer. Now, whether they were dislodged or always misplaced is a whole separate question, but 1 out of 4 were not in the right place when they crossed over the threshold. Perhaps, though, the most important corollary to that relates to how do we correct that problem. And this Orlando paper led to something I hope you're all aware of in North Carolina. If not, we'll cover it in just a moment, which is a simple intervention. They looked at, did the patient have continuous end-tidal CO2 monitoring, yes or no? If the patient had continuous end-tidal CO2 monitoring, the unrecognized esophageal intubation rate fell to 0. 0. In the absence of continuous end-tidal CO2 monitoring, it was as high as 23%. So, for those of you unaware, we were fortunate enough, the Duke Endowment granted money 4 years ago now to the EMS agencies across the state of North Carolina, and in every EMS system in the state of North Carolina, continuous end-tidal CO2 monitoring is now available, based in large part on this paper. So what we see is that initial airway management is difficult. Continuous airway management is even more difficult, and we'll cover that for the pediatric patient in just a moment. But my hope is that we all leave as zealots for pre-hospital end-tidal CO2 monitoring, because us or our loved ones had an airway managed. With these data, I think it's clear that's what we need to do. So to summarize thus far, the procedure, endotracheal intubation, can be done in less than 2 minutes. End-tidal CO2 seems to help make sure it's in the right place. However, there is zero evidence that this perfectly completed procedure improves patient outcome. And that's the power to question that I hope that we're going to enter into next, is the ability to do it well with end-tidal CO2 and direct supervision is probably okay. The question is, are we doing our patients any favors? So, have you seen Spaceballs? If you have not seen Spaceballs, leave now, because you need to see this in case the Lord takes you tonight. You don't want to leave this earth that I haven't seen Spaceballs the movie. In this particular scene, Dark Helmet there is getting ready to hit the ludicrous speed button. Does everybody remember the ludicrous speed button? Right, it's covered and it says never use. This study from Minneapolis was kind of damning for all of us in the EMS, and I want to take just a moment to tell you about this study. I have never, ever seen this happen in a hospital. Right. We'll talk about how this works in the ED as well. This group brought all the Milwaukee paramedics, and Milwaukee has an incredible resuscitation rate, one of the finest EMS systems in the country, have been for years and years and years and years. Great EMS system. They brought them in and taught ACLS, which says breathe 8 to 10 times a minute for patients in cardiac arrest. And they sent them out into the field. Well, what did they see? The average ventilation rate was 37 breaths per minute, plus or minus 4 breaths per minute. The rate limiter was how fast the bag would inflate in your hand. And so the duration of those ventilations was about 0.85 seconds for a total positive pressure time in the chest of 50%. So half of the time when you were trying to resuscitate a heart, you had positive pressure time in the chest, decrease in venous return, impeding your resuscitative efforts. They then brought them in and educated them, said, please slow this down to 10 breaths per minute. Group 2 got down to a whopping 22 breaths per minute as opposed to 37. However, they increased the time for each breath to 1.18 seconds. Therefore, the positive pressure time in the chest was not statistically significantly different. It was still above 40%. And then group 3 just went back out and didn't have the education, and you can see it started going right back up toward 37 breaths per minute. Now, I'm sure it's never happened here. Again, I'm just going to reflect on what I see at Wake Med and other hospitals. When we deliver patients to the pediatric side for trauma or to the pediatric ED, and they are being positively pressure assisted by us, by whatever mechanism, as soon as that bag touches somebody else's hand, it is a rhythmic squeeze like this. It is the easiest thing in the world to allow to have happen. And we'll make the argument that that can be a fatal problem. This is old slides, right? This is back when I was in medical school. We actually had to take tests on a piece of paper. I was talking to residents today about having to go take my board exam. And this is what I mean, go take your board exam. So I had to go to Atlanta because they only had one place to give it, and they handed out paper. They had no idea what I was talking about. Simple physiology, though. right? As we continue to stack breaths in the chest, then our functional residual capacity continues to increase. And so while we may still be getting a good tidal volume, we are starting at 4 or 4.5 liters in the chest rather than this normal functional residual capacity. So our ability to change this with an endotracheal tube is a part that we just do not respect to the point that we should, did reflect back on the box. Okay, so now you're saying, yeah, that's great. But the tube saves lives. It protects airways, right? This cannot be the case that this tube could be bad. We'll come to that. So I hope we're at our eureka moment, where we're going to talk about airway management in the broader sense rather than airway management in the narrow sense. So the Seattle experience, and those of us that are in EMS are kind of tired of hearing about these people, but in point of fact, they've done a lot of really good work there. And they have a 3,000-hour in-house paramedic training program. And unlike other systems that have paramedics on every engine and every ambulance, they limit the number of paramedics based on the procedures available in the community. So the response time of the medic has nothing to do with their quality metric. Their quality metric is, can we make sure every medic sees at least one airway a month? And we'll take the number of airways in our community and divide that by the number of medics, and that's how we decide how many medics we're going to have. So the response time is not part of their metric. They looked at all their patients transported to the Level 1 Trauma Center, and they looked at those who had received RSI versus those who had not, and there's a retrospective nature of this, of course. But look at the difference between these outcomes and the ones that we saw from San Diego. When we looked here, we actually saw an increase in good neurologic outcome in a statistically significant manner and a decrease in mortality in a statistically significant manner when these airways were managed. They were managed by individuals that do it often and that know the dangers of hyperventilation, and so they were not hyperventilated and they were well managed, and it appears that managing those airways indeed conferred some outcome. So that's a 2005 study. So I want to briefly reflect on some anatomy and the reasons that we get in trouble, and then we'll go to some case review, because case reviews are always better than physiology or anatomy. So we'll get there quickly. We all know this, right? These are the issues with the pediatric airway. The part that I think that we miss is not this during the procedure. We know that it's difficult during the procedure. I will tell you that across the state, the problems with pediatric airways, trauma or medical, mostly trauma, honestly, but trauma or medical, have less to do with initial placement and more to do with dislodgement. It is so easy in the pediatric patient for the little flip of that airway to become dislodged and it become unrecognized until bradycardia, hypoxia, and so forth, particularly in the absence of entitled CO2 monitoring. And here you can see one of the reasons is the airway makes a 90-degree turn rather than more that Mac Miller kind of turn, and so a little move makes that easy to happen. We also can see that the airway itself, the epiglottis makes it easier. It's just a more difficult airway, which is not lost on anyone here. The airway is more narrow as it goes down. The large occiput gets in the way. And then, all joking aside about our friends from NC State, ventilating these folks based on the laws of physics is difficult. If you take the same amount of edema and put it in an adult airway, you decrease the flow by about 44%, or decrease the resistance about threefold. You put a millimeter of edema in the same pediatric airway and you decrease the flow by 16-fold, right? Because it's radius to the second power that causes all of this trouble. So this is kind of the take-home about why it's difficult to manage these in a lot of different ways. We know the pediatric assessment triangle. I don't need to tell the folks in this room that. This is an interesting study, and I apologize, the slide when it formatted pushed the citation for this study off. It is in my notes at the bottom, so I will get you the citation for this. But they looked at pediatric intubation in the hospital environment. And for first pass success rate, for residents in the ED, it was 40%. For pediatric fellows, it rose to 70%, and for the attending, it rose to 72%. Once you allowed for all attempts, however long it took, the resident could eventually get it about half the time. The paramedic could get it 64%, the fellow 89%, and the attending 94%, but it took more than one pass. So performing this skill is difficult, and it's difficult particularly in the pediatric environment. Okay, so healthcare reform is coming. Which pantsuit you want to wear is up to you. And I think we have to reform our approach. And that's where I hope we're going to go. So this is our experience. And we've talked about our system, and I just want to give you a notion of why pediatric airway management is so difficult in the pre-hospital environment. We will respond to 90,000 requests for service this year. We will place 550 advanced airways. So far this year, we have placed 11 in patients under the age of 18. So to get an individual medic to have experience with a pediatric airway is incredibly difficult based on the fact, thank goodness, it doesn't happen all that often. But we have told our medics, you may do whatever you choose. You may bag them all the way to the hospital. You may put in a blind insertion device. You may put in an endotracheal tube. All we care about is, does your end-tidal CO2 look like you're ventilating? Is the chest rising and falling? Is your patient improving? That was a huge paradigm shift about 3 years ago. Before that, it was, I'm not going to the hospital without an endotracheal tube because somebody's going to make fun of me. Right? Quick aside story for those of you that work in the hospital. We looked at our trauma times for penetrating trauma, and we found that the pre-hospital time for trauma was identical whether you were shot or stabbed within a mile of the trauma center or 20 miles away. Say that one more time. The pre-hospital time was identical. And we asked the crews why. And they said, well, if I'm near the trauma center, I've got to get my IVs started before I leave because the trauma nurse is going to make fun of me if I don't have IVs when I come in with a major trauma. So they knew 20 miles away, they had 20 miles to start the IVs, so they were starting them en route. When they were close, they were sitting on the scene to get it done because of the way the nursing staff was acting. And that's a true statement, and I stood there and watched it. It's nice to wear a uniform sometimes and stand in the corner. They don't know who you are. And so I was watching how this goes, and they were convinced, you call this level 1 trauma. There's no IV started. I thought, for goodness sakes, it's in your scope of practice. Start some IVs and hush. So the point's the same here. We had crews that were forcing themselves to go to an airway because they did not want somebody to say, what do you mean you couldn't intubate that kid? Right? And it took some time to move to overall airway management. So this is a nice distribution. The other is a patient with a chronic trach that had trach problems, and we hooked to the trach. So the other was not a surgical airway for us. We don't do pediatric surgical airways, nor publish anybody, but that other is not a surgical airway on our part. I just want to be clear about that. Okay. So we're going to talk about 3 cases. And I hope these will be illustrative of how we manage pediatric airways in the pre-hospital environment. Case number 1 is an unfortunate case that has been repeated in our community. I think it was 5, it may have been 6 times during this summer season. All of these cases occurred in community pools, most of which had a lifeguard present. And in this particular case, there was a 10-year-old male who could not swim, who was in the short end of the pool, the 3-foot area, last time he was observed by family members that were there. He was subsequently found in the 8.5-foot other area of the pool, and he had been under for who knows how long. So it was an unknown, unwitnessed, found down at the bottom of the pool type of thing. And so EMS was summoned. And for us, this is a trauma case in our system. Bystander CPR is in progress on EMS arrival, so that's good. The initial EMS interventions were an oral airway with a BVM. The monitor demonstrates asystole, and the patient has continuous compressions. So, based on what we know now, how many people are going to move to another airway for this patient? Nobody's willing to, because they all know. In point of fact, we will in a moment. So we start an IO. We provide some epinephrine, some vasopressin, some bicarb. It is the 3rd intubation attempt, but it is the 2nd provider. So one provider tries twice, recognizes they're unsuccessful, bags in between. The more experienced provider has arrived, comes in, places the tube, and we have ROSC 16 minutes after the first EMS arrival. Good end-tidal CO2s and so forth. It begins in the high 80s, so we know that there's been some perfusion during this CPR. It comes into the 40s and stays with a nice waveform all the way to the hospital. The SaO2 was 100% directly after intubation. And for those of you in the ICU, that's a good sign, but you know in the drowning situation like this, it's going to be difficult for it to stay in that range, and indeed, even with us, it starts to fall en route, and we'll talk about what goes on with that in a moment. Our respiratory rate, we still, even though we have preached it left and right, we occasionally got a respiratory rate up to 20. The good news is that we've got a little timing light, and that somebody kind of refocused and got that respiratory rate back down, so we were only in the 20s for a very short period of time. Pulses looked great, blood pressures looked great. The patient was eventually admitted to the PICU. Hypothermia therapy was started, which we can have a discussion about during the question and answer session if you'd like. The patient had multiple episodes of cardiac arrest, could not be oxygenated by any mechanism, and unfortunately died 10 hours after admission. So we had a successful placement. We had initial okay SATs, but we know from our history with dealing with these drownings that they get ARDS fairly rapidly, and some of them just have a very rapidly deteriorating course. This was one of 2 in the same week in our community that had this exact same outcome from a community pool. It was a long week in Raleigh. Case number 2, I am not sure actually got struck in the chest, and we'll talk about the case, but that seems to be the most likely thing. We talk about this as if it's the most common thing that happens in the world. In point of fact, there's a registry in the country, and from 1998 to 2007, there were 188 total cases. So it's not extraordinarily rare, but it's fairly rare, and fewer than 20% of these patients survived. And we'll talk about this particular patient and how we managed his airway. This was a 13-year-old male. He was playing a pickup football game, and it was in a park/parking lot. And apparently whoever was quarterbacking at the time had more arm than they thought, and so they ended up across the sidewalk and into the parking lot trying to catch a pass, is what happened. It is unclear to us to this minute, because he was between 2 cars, whether he caught the football in a weird way in his chest, whether he struck one of the parked cars, but at any rate, he was found down between 2 cars in cardiac arrest. There were 2 nurses and a respiratory therapist that happened to be at the park on this scene. So they pulled him from between the car, and they started aggressive and appropriate bystander CPR. The fire department first responders arrive. They continue the compressions. They place an OPA and utilize their bag valve mask. The AED advises a shock. The shock is delivered, and the patient has return to spontaneous circulation thereafter. EMS finds the patient with assisted ventilations from the firefighter first responders. This is his vitals at the moment. He has pulses in the 110s to 130s as a 13-year-old, recall his age. Blood pressures look good. SATs are okay. GCS is 3, and then the patient starts to seize. This historically would make us all very worried, right? I mean, immediate post-ROSC seizure activity historically would lead you to believe there may be a bad outcome. The crews gave 2 doses of 5 milligrams of Versed IV, and were finally able to get the seizure to stop. What is interesting is that he continued, even after the 10 of Versed, to have spontaneous respirations at 8 to 10 breaths a minute, which were simply assisted with the bag valve mask. He had no purposeful movement, no neurologic function, so we were starting to cool him in the pre-hospital environment as well as soon as we found that to be the case. His intubation was completed in the trauma bay. So we bagged this gentleman all the way to the hospital with good end-tidal CO2 and good SATs and no problems. I probably shouldn't tell this story, but I guess it's okay. When I was doing my residency at CMC, we would go to the pediatric OR and bag the appendectomy cases all the way through. There was no adjunct other than oral airway. And the point they were trying to make is it's easy to do. You can bag a pediatric patient for a long, long time. Now, of course, these were known NPOs. It makes it a little bit easier, but the point is you can do it for a while, and we did it for a while here. He underwent his trauma scans just to be sure he hadn't hurt himself running in the car or what have you. They were all negative. He underwent 36 hours of hypothermia therapy, was awakened, and was seen by neuropsychiatry. And the only deficits he had was a mild delirium as they removed the sedation. And once the sedation cleared, he had perfectly normal neuropsychiatric testing after that. So he's back home and doing well. Actually, last we heard, we think performing even at grade level, the best we know. Case 3, and you may have seen this here, certainly going on across the country, one of the more common mechanisms for attention grabbing / true suicidal attempt versus other autoerotic things. There's a lot of hanging going on in the age group about 13 to 18, and we see quite a bit of it. This was a 13-year-old boy who was found hanging in the bedroom by the mother. This was an unfortunate case of a previously healthy no known psychiatric diagnosis. In fact, no medical history. 13-year-old that got in a fight with his mother and stomped off to his room and hung himself. So it was a very difficult scene all the way around. When the fire department came, they found the patient in the floor. We, to this day, do not know what was used to hang the child. There were ligature marks around the neck. The mother apparently had done something to get the child down to the floor. EMS found the patient to be cyanotic with a respiratory rate of 4, pulse rate of 98 that were palpable at the radius. Obviously, the respirations of 4 were profoundly ineffective, but he never actually, to our knowledge, suffered true cardiac arrest. He had respiratory arrest from this event. So the bag valve mask ventilations, again, demonstrated good compliance, improved color. Pulse came up in the 100s to 120s. SATs initially 88, rose to 97. End-tidal CO2 stayed right in the middle of a nice range throughout this transport, and he was moved to the EMS unit to go to the hospital. He began to have emesis, or if you watch Ducky tonight on NCIS, emesis, right? He has odd pronunciations of some of that stuff. And so this goes back to that argument of, well, you got to intubate people because you got to protect the airway because they might vomit. Well, they might, and then you take care of it. And so we tried a nasotracheal intubation because we don't do paralytics in our system, which we can talk about in question and answer if you want, but nasotracheal intubation, which initially was successful. The patient, fairly quickly thereafter, became more combative and removed that nasotracheal tube. So we went back to the bag valve mask and were able to continue good end-tidal CO2s, good measurements of pulse oximetry, and manage that airway with the bag valve mask all the way to the hospital. And it continued to be effective. He had negative CT scans. He was intubated in the emergency department, and I must say, in a non-urgent way. He was bagged for some period of time in the ED while we were talking about everything that we were going to do. He underwent 72 hours of hypothermia therapy, and I can't give you a shred of evidence to tell you why we went long. I just know our PICU folks are very aggressive with hypothermia. The joke is do not stub your toe and go to the PICU because they will cool you to make sure that works. And so they went long, and we're not exactly sure why they did that, but he was discharged with only a mild amnesia and intermittent confusion. Neuropsychiatry noted at discharge felt that he would improve. They were unsure if he would return completely to baseline, but he certainly was verbal, functional activities of daily living. All of that was okay, and they were hoping that what neuropsychiatric deficit they saw would continue to improve. And with that, I'm going to take just a couple of minutes and digress and talk about this hanging thing because it's an interesting deal. Whether we should be cooling and airway management for these is kind of an unknown at the moment. But there are very few cases in the literature. There are 2 case reports of patients that actually had cardiac arrest that went on to have hypothermia and did well. 2 case reports is not enough to guide us by any stretch of the imagination. There's a literature review for the big study, as I call it, which had a whopping 13 patients in it. And if you look at the literature review, you see those in the non-cardiac arrest off to the right, which is our patient. Those that received therapeutic hypothermia went 5 for 5. Well, I don't know, does that guide therapy? That's a little low end for me, but that's what's out there. So then there really is the big study. That was 13, now there's 14. So we've got 27 plus 2, there's 29 total cases in the literature of hypothermia as it relates to caring for a patient after they've had a hanging episode. And we won't go through all of this other than to say it's interesting to me. If you cool them and their CT is normal, they do well. If their initial CT is bad, they do poorly. I think we knew that before we saw this, right? I mean, if you come in immediate post-hanging and you've already got radiographically demonstrable changes on your CT scan, it's a kind of foregone conclusion you're not going to do particularly well. But it does at least, I think, give us this notion that there are things that we can do that would be beneficial potentially. So the authors of this study lead with this, and I think this may be where we are, which is near hanging victims presenting in the hospital alive generally have a good outcome unless they've suffered cardiac arrest. All of these studies are too small, but based on what we know, we ought to manage their airway and probably cool them until we know better, and we only got 29 patients with which to guide us. So at the moment in our system, we have specifically excluded drowning and hanging from the contraindications for cooling, because cooling is a medical enterprise. Trauma people worry about cooling, but those 2 we've agreed will be cooled on the standing order set or whatever it is, Joint Commission, let's just call that. We can't call it a protocol, it's a standing order. Is that the right phrase? I never can remember what it's okay to call it. All right, so we'll summarize and take questions. Here's the summary. There is insufficient evidence to guide us about how to manage pediatric airway. Almost all studies show equivalence of the different airways with potential harms from each. The bag valve mask, you worry about aspiration. The endotracheal tube, you worry about misplacement and inadvertent hyperventilation. And so you have to manage that airway in the broader sense and pick between the ones that seem to be the best. All we have in the pediatric environment really is a case series and the expert opinion to guide us over what we should do. So in my mind, this is hopefully the take home. It appears reasonable to do this. First, regardless of how you're managing that airway, we should have continuous end-tidal CO2 to assure ourselves that ventilation is ongoing and the airway, whatever it may be, is in the right place. In our system and in our approach, we hold bag valve mask, a blind insertion airway device, so your King, your LMA, whatever that may be, and endotracheal intubation as equivalent. And we say to our providers, take the entirety of this circumstance into account and use the best airway that you have. And I think that football player into the car is the best example of that. We started with a bag valve mask. We had vomiting. We didn't like it. We put a nasotracheal tube. That didn't last. We didn't like it. We pulled it. We went back to a bag valve mask. And he came out neurologically fine on the other side. So this notion that you have to have one or the other to have good neurologic outcome is not really the take-home from my perspective. Continually reassessing these pediatric airways cannot be overemphasized, particularly in that pre-hospital environment. An initially well-placed, whatever it may be, is very prone to dislodgement during the activity of an EMS transport and all the other things that are going on with these critical patients. So in my mind, that is absolutely critical as we go forward. So with that, I will stop and take comments or questions that you may have. Yes, sir. Yeah, so the question is, can you get hyperventilation with just a BVM and an OPA? Yes, you probably can, but you have to have a pretty good seal, and I would argue that most folks cannot get a sufficient seal to cause that increase in thoracic pressure nearly to the extent you can with an endotracheal tube. It's still a problem. It's still a possibility. I think the physics of us not having the perfect seal throughout the entirety of the time actually work in our favor, so we get a little exhalation from it. But certainly it can be done with anything. You know, in our system, the timing light goes on the top of the endotracheal tube. If we don't have that, they tape the timing light across the chest, so the bag valve mask, you're still seeing the once every 6 second blink to squeeze the bag at once every 6 seconds. But yeah, you can do it anyway, but the endotracheal tube makes it a heck of a lot easier. Good question. Yes. Yes. No. Can we go? So the blind insertion airway device. There are animal studies that demonstrate the capacity with which you have to fill that balloon in the animal will decrease carotid blood flow. So we can demonstrate a decrease in carotid blood flow in the animal model from a blind insertion airway device. That's not been demonstrated in the human. There are preliminary studies that would indicate placing the endotracheal tube at some point in the pre-hospital run may be superior to leaving a blind insertion airway device, but in all of those studies, bag valve mask is still the best. So I've often thought if we had to get the endotracheal tube in the pre-hospital environment through the FDA today, we would never be able to get it approved because there's no science to support its use when you compare it to bag valve mask almost always. The blind insertion thing is still a big debate, both in the adult population as well as the pediatric population. You saw from our stuff, we've only used 1 out of 10 airways, I mean, for whatever that's worth. But when you look across, most people don't feel comfortable with that blind insertion airway device in a pediatric patient. They either want to bag them or they want to tube them, and there's probably good reason for that. But if you're asking for data, there are no data to guide us as it relates to blind insertion airway device in a pediatric patient. The only place I know that really has a protocol, if you will, looks at, and it's the Houston Fire Department. They will use blind insertion airway devices for resuscitation And then once a pulse is returned, they will change that over to a tube at the scene before they leave and go to the hospital. They don't have any evidence to support that either, but it has a nice ring to it. But I think it's part of the direct answer question. I think it's part of the armamentarium. I think it's less important in the pediatric population than it is in the adult population. Yes. So the question is, if we have a child that is incredibly small, can we still get good end-tidal CO2? We have found, yes. We have had a 27-week preemie delivery in the pre-hospital environment that had perfect end-tidal CO2s. We are using that, though, in those situations between the mask and the bag. These are not on endotracheal tubes in the vast majority of cases. So it is a true measurement at the bag valve mask level. But no, we haven't seen any issues with that. Yes, ma'am.
Well, to answer that question, we use antennas in our pediatric patients, but our neonatal will do like a transcutaneous sensor protocol. So you do your entitled, CO2 is about a half a cc of dead space onto the tube. So I think we only do it like.
Right. And that's a very eloquent answer, which I appreciate. From an EMS perspective, we have to allow for that dead space and move on. But yeah, you're exactly right. You have to generate at least enough tidal volume for the negative pressure in the line to pull it up.
The EMS controls, what we do is neonatal pediatric transport nurses and therapists, and we're controlled by their guidelines, so we have to do a lot of stuff that they have to do, and we don't pick up EPCO2 well on these babies.
Yeah, and I'm sure when you get a tidal volume low enough, it is difficult. I mean, there is a point at which that negative pull to go to the monitor, because all of these work the same, right? They have a little stream, and you've got to have enough air to move that stream for the monitor to pick it up. So in the very young, it's difficult. But, reflecting on a 911 service, we just have not seen that issue. But we don't do this very often.
I know, but your guidelines, or their guidelines.
Whoa, my guidelines, good gracious. Well, they do, and I want to be clear about that, and I'm going to probably step on it here, but specialty care transport can write protocols off of the INSEP guideline that 911 services cannot. So if you're a part of a specialty care transport, there are other options that you can put in your protocols that would be cleared through the state. So just keep that in mind as you're looking at it. The 911 side of those protocols is fairly locked down. The specialty care, helicopter and ground critical care has a lot more leeway.
Now, does that take a lot of work?
No.
I mean, because this is something that I've been asking forever.
It does not take a lot of work. And Trip Winslow is right here, who's the state medical director. I'll give you his number. Yes.
Anyone measure the numbers of the patients who had the bag valve mask en route that were not intubated once they arrived at the hospital versus if they intubated in the field when they arrived, they continue to be intubated?
So let me make sure I understand the question. The question would be, are there some patients that get better? In other words, we bag them through and therefore they don't need further airway management. I don't know of anybody that's looked at that. It's an interesting question. And again, for us, it just goes back to, 350 EMS providers with 11 airways a year. We'll do 3 or 4 more, so say 15. That's just a very difficult skill to maintain. And the bag valve mask seems to work in the vast majority of cases. So, but no, I don't know that anybody has looked at, did some subsequent treatment make them better, and therefore they avoided the intubation altogether. I don't know of anybody that's looked at that. It's a great question, but I don't know if anybody's looked at it. Yes, oh, sorry.
Do you do standard bag valve mask all the time, or do you do like PSAB in your pre-hospital transport? I'm at PSAB hospital.
Sure. So no, ours are all standard. We have the 3 sizes, right? There's the infant, the pediatric, and the adult. But as far as the ability to titrate the PEEP at the actual valve, we don't have any of those on the units. I'm the last thing between you and lunch, I can tell. Okay, well, I'll stay and take personal questions if you don't ask them for everybody else, and thank you all very much for having me. I appreciate it.